So today we're going to be talking about lid retraction in neuro-ophthalmology. Obviously we're not going to be covering the things that cause lid retraction from scarring or from trauma or those mechanical things. The most common cause of lid retraction, either unilateral or bilateral in the adults, is thyroid eye disease. And it's not clear exactly what causes the lid retraction in thyroid eye disease. And when I'm looking for lid retraction, I'm looking for the lid to normally just cover 1 to 2 millimeters of the top of the limbus. And so if it's at the limbus or above, I consider that to be lid retraction. And so when we see lid retraction, we're going to be thinking about thyroid eye disease first, and that means doing a Hertel to look for proptosis, to be asking the patient about their thyroid history, and to be looking for lid lag, which is the lid lags in down gaze, so it doesn't follow smoothly. And so the combination of proptosis, lid lag, and lid retraction is highly suggestive of thyroid eye disease. We're going to do the thyroid function studies as well as the antibodies, TSIG and TPO. And you might image the patient either with ultrasound to find the big muscles or CT of the orbit, non-contrast, to see the same thing, big muscles. However, there are neurogenic causes of lid retraction, and the one we're worried about is called the Collier lid retraction side. So when we see a patient who has lid retraction, we're going to be looking for other features of the dorsal midbrain syndrome. The other features are convergence retraction nystagmus, light near dissociation of the pupils, and up gaze paresis, but it can also be down gaze. And if we see that constellation of features, we want to make sure to image the patient looking at the dorsal midbrain. So any patient with lid retraction, we must look at their motility and we must look at their pupil. And the key and differentiating feature is going to be light near dissociation, because thyroid eye disease doesn't cause pupil abnormality. It could cause the up gaze paresis, it could cause the lid retraction, but what it can't cause is a pupil involvement. So light near dissociation and convergence retraction nystagmus are going to be the key features to suggest this lid retraction might be neurogenic. And sometimes we have lid retraction because we have aberrant regeneration. So normally the third nerve controls the lid and the levator and the extraocular muscles, except for the lateral rectus and the superior oblique, as well as the pupil. So when patients look down, they might get looks like lid lag. The lid retracts when they look down, but really the lid is firing when the inferior rectus muscle is firing, and that is aberrancy of the third nerve. So the nerve to the inferior rectus is growing to the lid now, and so the lid retracts. So we can get a von Graefe sign in thyroid eye disease, but we can get a pseudo von Graefe sign in aberrant regeneration of third nerve. And so we're going to be looking for ophthalmoplegia and the pupil involvement as well in third nerve palsies with aberrancy. And finally, you can get one eyelid retracted and the other eye could be ptosis. So if we have ptosis in one eye, but we have retraction in the other eye, that is called the plus-minus syndrome. So the plus is the retracted eye, and the minus is the ptotic eye. And where this plus-minus lesion can occur is in the midbrain again. And so if you're in the midbrain and you've got a third nerve lesion, so you could get the dorsal midbrain syndrome, which is causing the Collier's lid retraction sign, but because the lesion extends ventrally as in involving the third, you'll get a ptotic lid on one side and a retracted lid on the other side. So you have a dorsal midbrain syndrome producing supranuclear inhibition on the levator, causing lid retraction, the plus, but because the other eye has a third, it'll be a ptotic lid, and that is called the plus-minus syndrome. So the plus-minus syndrome is a sign that we should be imaging the brainstem at the level of the dorsal midbrain, but it has ventral extension to involve the third nerve fascicle and is causing a ptosis. In addition, thyroid eye disease, which causes lid retraction, can be associated with ptosis on the other side, and that is from myasthenia gravis. As you know, both thyroid eye disease and myasthenia gravis are autoimmune disorders that can occur between 5 and 15%, have both conditions. And so the combination of retraction on one side and ptosis on the other is a plus-minus from thyroid eye disease. So we have a plus-minus sign, and it could be the plus-minus sign, ptosis and lid retraction, from a plus-minus syndrome in the dorsal midbrain, or it could be a plus-minus sign from a pseudo plus-minus syndrome. It's actually two disorders, the combination of thyroid eye disease causing lid retraction and ptosis in the contralateral eye caused by myasthenia gravis. So Neuro-op, you should know about lid retraction. Think thyroid, thyroid, thyroid. If it's not thyroid, make sure it's not aberrant third or the Colliers lid retraction sign. And think about plus minus in patients who have both ptosis and lid retraction.